It's really pretty often that we have experts from our own faculty who go around the world and give talks, and we never ask them to give talks here. So we're trying to fix that problem. And so our speaker today is Ian Krop. I think many of you know Ian. Ian came here a month after I did, 3 years ago from Dana-Farber. He spent most of his life up until about age, I don't know, somewhere in his mid 30s at Hopkins, where he went to college and medical school and got his PhD and trained, and then came to Dana-Farber, where he was a fellow and stayed on the faculty for quite a number of years. He is a breast cancer expert known around the world. And for the purposes of today's talk, he's also an expert in antibody-drug conjugates. In fact, he ran the first phase 1 trial of the first antibody-drug conjugate that was approved in solid tumors, and that was TDM1, now back a number of years ago. So I'll also mention that Ian is the chief scientific officer for the Translational Breast Cancer Research Consortium here at Yale. He's our chief clinical research officer and runs the clinical trials office. So, Ian, please.
Good afternoon. Thank you for that kind introduction. We're going to be talking about antibody-drug conjugates, which I think this is a particularly opportune time to have that discussion. This is an area that's moving very quickly. There's actually been 2 FDA approvals of ADCs just in the last 8 or 9 days, and that's just within breast cancer. So there's a lot going on. And what I thought I would do would be to talk about ADCs using HER2-positive breast cancer as kind of an example. And the reasons for that selection is because HER2-positive disease is an area where we've had the biggest clinical impact of targeted therapy in general and ADCs specifically. Interestingly, we see a benefit of ADCs across a very wide range of target expression in this subtype of breast cancer, which I think is worth talking about. There's examples of basically all the key features of ADCs are kind of manifest in HER2-positive disease. And lastly, this is what I study, so I have most of the slides, so it was easier. So just for those of you who don't treat breast cancer, HER2-positive disease makes up about 15 to 20% of breast cancers, and these cancers have dramatic overexpression of this cell surface protein tyrosine kinase called HER2. There's typically 1 million or even 2 million copies of HER2 protein on each cancer cell. These cancers are typically high grade and they present with more advanced stage. They recur more frequently and they have resistance to standard therapy. So these patients had very poor prognosis prior to the realization that the reason these cancers were behaving so badly was because of this dramatic overexpression of HER2 and all the downstream signaling that was happening because of that. So that led to the development of drugs targeting HER2, the first of which was an antibody called trastuzumab, and it was shown back in, I think, 1998 or 1999 that the addition of trastuzumab to chemotherapy led to substantial improvements in outcomes, progression-free overall survival. If you use it in early stage disease, it increased the cure rate by about 50%. So it was a clear breakthrough with this HER2 targeted therapy introduction. And it really, in many ways, met the criteria of the Nobel laureate Paul Ehrlich's idea of a magic bullet, a drug that specifically targets a pathogen while sparing normal tissues. And actually, Dr. Ehrlich was thinking about chemicals and chemical dyes originally, but we use it in terms of thinking about antibiotics and antibodies as well. So this feels like it met those criteria. But the problem, particularly in HER2-positive disease, was that for trastuzumab really to work, you need to have chemotherapy around. You need to have some type of cytotoxic agent. And that's because one of the things trastuzumab does is helps encourage apoptosis, and you need something to produce that apoptosis, and that's where chemotherapy comes in. But you have this very targeted antibody, the magic bullet, and then you throw in non-targeted chemotherapy. So you lose some of your magicness when you have to have chemotherapy around. So this was a perfect opportunity to take advantage of this then very new type of technology called an antibody-drug conjugate. This is a very simplified diagram, obviously, but the idea of an ADC is you have an antibody targeting some cell surface protein, and you have a very cytotoxic moiety, typically a potent chemotherapy, and you attach them with a linker that's typically cleaved once, or the idea is that it's cleaved once the conjugate gets inside of a cell, with the overall goal that you're going to increase the efficacy of the cytotoxic drug while decreasing the toxicity by selectively delivering this to the cancer cells. So these are the conjugates you talk about, guided missiles, smart bombs, whatever warmongering terminology you want to use, but that's the general idea. And so the first of these, as Eric had mentioned, to really become clinically useful in solid cancers was this one called trastuzumab emtansine. And the idea of ADCs actually had been around for decades. The problem is none of them really worked. And the main problem they were having in the past was toxicity, because the linker tended to break in blood. So you had dissociation, so you had lots of free cytotoxic drug floating around, and that was causing nonspecific toxicity. And so what was different about TDM1 was that it started with this trastuzumab monoclonal. It's a touchscreen. It starts with this trastuzumab monoclonal targeting HER2 that we talked about. It had a microtubule inhibitor payload, and the linker in this case was actually not cleavable. So I talked about the idea of generally these are cleavable. This one was not. And its story is kind of interesting how that came about, and I promise this is the only chemistry I will be talking about today. So when Genentech was trying to develop this drug, they were really trying to make for a more stable linker. Because again, the problem in the past would be the linkers weren't stable, and so you were getting toxicity. So they said, okay, well, let's try to make this super stable. And so they were testing a number of different chemical structures, different cleavable linker chemistries and distances between the antibody and the payload. And they threw in at the bottom of their experiments this MCC linker, which is basically non-cleavable. And they put that there as a negative control, because of course this wasn't going to work, because if you don't have a cleavable linker, then you can't release the drug to kill the cancer cell. So they threw that in there just as a control. And what they found was, as expected, that the non-cleavable linker, the MCC in blue there at the top, was very stable in plasma, the most stable, and it was stable different ways of looking at it. And actually it was pretty well tolerated because you weren't having this dissociation in blood. But the surprise was that it also was the most effective. And so the blue line at the bottom there is the TDM1, essentially. And so the way this was realized, what was happening was that you have the conjugate, the TDM1 binds to the cell surface on the HER2. It gets internalized into lysosomes, where the proteases actually would dissolve the antibody, essentially. And so you didn't break the linker. It's just the amino acid, the lysine from the antibody where it's connected, would just leave with the drug attached to it. And so that's how this drug was working, and that's how you got this selective delivery of the DM1, was because the antibody was getting just proteolyzed. So, as Eric mentioned, we were involved in this phase 1 trial, the first in human study of TDM1. We enrolled patients who had already progressed on multiple HER2-directed therapies. And despite that, and despite this being just the phase 1, there was a lot of efficacy seen. So the 44% response rate, these were durable responses. The progression-free survival was about 10 months, and 73% of patients had some benefit. And at the same time, not only was it efficacious, but it was very well tolerated. So we didn't see the usual chemotherapy side effects. People generally didn't get nauseous or have neutropenia or neuropathy or hair loss. And so it probably, and the reason why was because the amount of the free payload, which is in black here, was very low, was negligible. So it really wasn't releasing that payload very quickly as the hope, as was hoped. We then moved to a phase 2 trial, again in very heavily pretreated patients, and I'm just showing this because it's probably the first trial that Eric and Pat LaRusso and I did together back in the day. And we saw the same thing, heavily pretreated patients, response rate was reasonable and it was effective. And then we moved on to do a registrational phase 3, 2 phase 3 studies, this one in patients who had already progressed on all standard therapies, showing that TDM1 was better than the standard of care in terms of survival and PFS and was less toxic. And similarly, this is a earlier line trial, again, showing better efficacy and less toxicity compared to the standard of care. So these trials led to the approval of TDM1, as you heard, I think in 2012, as the first ADC in solid cancers. And really it did a couple things. It validated HER2 as a target for an antibody-drug conjugate. But most importantly, as being the first success in a common cancer, it led to the widespread development of ADCs across tumor types. So at last check, there were 370 ADCs in clinical development, again, spurred on by the success of this drug. And it also inspired people to start looking at better technologies for linkers and payloads. And that's probably been best exemplified by this next generation drug targeting HER2, which is called trastuzumab deruxtecan, which differs in a few ways. It has a different class of payload. It's not a microtubule inhibitor. It's a topoisomerase inhibitor. But perhaps the most unique feature was that it evidenced this thing called bystander effect. And the reason it did this is because it had a different linker that was cleavable by proteases inside the cell, and that led to this bystander effect, which I'll try to depict here. So the conjugate now binds to the surface of the cell, gets internalized, the payload's released, and if you'll excuse my grade school animation, that once that payload is in the cytoplasm, unlike TDM1, in this case, there's no lysine attached to it. It's thus membrane permeable, and so it can diffuse outside the cell and kill neighboring cells, even if those neighboring cells don't have HER2 on their surface. Why is this important? Again, we're targeting a HER2-positive cancer. Why does it matter that this drug could work in cancer cells that don't have HER2 on them? Well, and I'm sorry, this just shows that this bystander effect really seems to work. So this is a xenograft on the left of a combination of a HER2-positive cell line and a HER2-negative cell line. HER2-positive stains brown by IHC. And if you treat with TDM1, as shown in the middle diagram, you kill off the HER2-positive cells, but you leave behind the HER2-negative cells, again, because TDM1 doesn't have this bystander effect. But on the right, you use TDXD. With bystander effect, you kill off both cell lines. Okay, again, why does that matter? This is a xenograft where you mix two cancers together. Obviously, people have one cancer, and it's HER2 positive, so there should be lots of HER2 on all the cells. Well, let's just, for the sake of argument, say that's not the case and that there are heterogeneous expression of HER2 in some cancers. The concern would be that if you have this heterogeneous cancer, as shown here, where the blue cells are the HER2 positive and the red ones are not, you treat with a very targeted drug, you kill off the HER2 positive cells, you leave behind the HER2 negative cells, and the HER2 negative cells then grow up, and now you have a resistant cancer, similar to what was shown in the xenograft I just showed. Is this clinically relevant? So my colleague Otto Metzger and I did this IIT to ask this seemingly pretty straightforward question, but at least as far as we knew, that really hadn't been addressed before in the clinic. Are heterogeneous cancers less sensitive to targeted therapy? So the way we did this, we took 164 patients who had newly diagnosed HER2 positive disease. And before we started treatment, we did a biopsy in 2 different locations of their cancer. And then they treated with T-DM1. We threw in another HER2 antibody called pertuzumab, and then they had surgery. And so we took advantage of the fact that we did these 2 different biopsies. And so we had, and each of those biopsies had 3 different sections that we looked at. And we looked at whether there was heterogeneity in terms of HER2 amplification in those different sections. And we scored those cancers using a standard ASCO CAP definition of heterogeneity. And then we looked at how the heterogeneity played out in terms of benefit to this treatment. And what we found was that in the cancers that were not heterogeneous, those cancers where there's pretty homogeneous expression or amplification of HER2, 55% of those patients had complete eradication of their tumor just from the HER2 targeted therapy. So in that situation, this HER2 targeted therapy is highly effective and well tolerated. But then when you looked at the cancers that were heterogeneous, none of them had a pathologic complete response. And so this was highly statistically significant, and it confirmed that actually heterogeneity matters, that if you have a heterogeneous cancer, you're not as likely to respond as completely to HER2 targeted therapy, or at least a HER2 targeted therapy that doesn't have this bystander effect, which T-DM1 does not. We actually went on to look a little bit more in depth in collaboration with a lab at Dana-Farber led by Nellie Polyak and Francisco Mejor, looking at the single cell level by HER2 amplification, trying to understand what was actually driving the resistance. And interestingly, or at least interesting to me, it was actually the fraction of the non-amplified cells within the population that was strongly correlated with PASCR. And so originally we kind of had the idea, okay, a heterogeneous cancer is one where there's a big sea of HER2 positive cells, and then there's this little cluster of HER2 negative cells that was going to stay behind and grow out. But actually, that's not what we saw. It's actually fairly oftentimes relatively uniform distribution of HER2 positive and HER2 amplified and HER2 non-amplified cells that was leading to heterogeneity. So you didn't actually have to do those 6 biopsy sections. If you just look at one section and you quantitate how many of these HER2 non-amplified cells are there, you can actually predict PASCR very strongly, which is kind of interesting. And our data was subsequently replicated a few years later in a larger trial where they went back and looked at the same population, patients treated with T-DM1 and pertuzumab. And again, those who had heterogeneous positivity for HER2 had no PASCRs, whereas those that were homogeneous had an over 50% PASCR rate. Okay, so getting back to T-DXd, it's got this bystander effect, at least in vivo. Does that matter in terms of improving efficacy? So it does, or at least somehow it has much better efficacy. Whether how much of that's bystander effect or some of the other aspects that we don't really know at this point. But this was a phase 2 single-arm study that we were involved with that demonstrated in heavily pretreated patients who had already had all of the standard HER2 therapies, I think the median of 6 prior lines. So these were 7th-line metastatic patients, and the response rate to T-DXd alone was over 60%. It was very durable. The patients were on study for over 20 months, and virtually 100% of patients had some benefit, as shown in this waterfall plot. The trade-off was that there was more toxicity. So unlike T-DM1, with this drug, most patients get some nausea, there's fatigue, there's hair loss in some patients. And in 10 to 15% of patients, they get a serious complication called interstitial lung disease or pneumonitis, which is typically manageable, but it's definitely something that you have to pay attention to because it can be fatal. So because of the incredible efficacy in very refractory patients, these data led to the accelerated approval of TDXD in this kind of refractory setting. But then we went on, there were several other trials. This was a phase 3 trial looking specifically at patients who had already had the other ADC, TDM1, and comparing TDXD versus standard HER2 therapy, and TDXD was much better. And this demonstrated that you actually can have benefit from one antibody-drug conjugate followed by another, even though they have the same target, but they have different payloads. So by switching payloads, you're able to provide more efficacy. And at least in my mind, this supports the paradigm that you could treat patients with sequential ADCs with different payloads. And we'll talk more about that later. This went on to now look head-to-head at TDXD versus TDM1, so two ADCs against each other, probably the only trial that's done that. And again, TDXD was far superior to TDM1, fourfold greater progression-free survival, so almost 29 months progression-free survival, a level that I don't think had ever been seen before in pretreated patients with breast cancer. So very effective. Survival was also beneficial. And this established TDXD as the standard care for patients with HER2-positive metastatic disease. But there was a question at that time of, well, what about patients with progressive brain mets? And unfortunately, that's a big problem in HER2-positive disease because for reasons that aren't completely clear, there's a strong predilection for HER2-positive breast cancer to go to the brain. Partly it may be because, or part of it may be the conventional wisdom that drugs like that we use in HER2-positive disease, like antibodies, antibody-drug conjugates, don't get into the brain into the brain because of the blood-brain barrier. So it's kind of a sanctuary site, and that's why we see so much of it. But there's also some biology involved that these cancers are just have a tropism to the brain. But as I said, the idea was antibodies don't get into the brain, therefore antibody-drug conjugates don't get into the brain. So how could a drug like TDXD work in this very common situation? But it turns out that actually antibodies can get into the brain, at least somewhat. This is a PET label trastuzumab study, and you can see on the bottom there that actually the antibody does get to the brain metastases, at least to some level, probably because the blood-brain barrier breaks down a little bit when you have a cancer there, and it's disrupting, it causes dysregulation of vasculogenesis, so the blood-brain barrier isn't quite as intact. But regardless, some antibody can get there. And so we actually went back and looked at the large studies I just had shown you, and there were a small number of patients on those studies that actually had progressive brain metastases at baseline. And we looked at the intracranial response of TDXD, and actually there was some response. It was about a 40-something% response rate in the brain with this ADC, but the sample size was pretty small. But just recently presented at ESMO a few months ago was a prospective study of over 250 patients with brain metastases treating with TDXD. And as you can see, response rate in the brain with active brain metastases was over 60%. So I think we now have pretty definitive data that these ADCs actually are quite active in the brain. I think that's important to know since we obviously have a lot of cancer types that have brain metastases as a major problem. And so this idea that you have to use small molecules is probably not true. So as you might expect, with the efficacy of these conjugates in patients with metastatic disease, there was interest in seeing whether these conjugates could also work in preventing recurrences in patients with early stage disease. And so originally there was a large trial that looked at patients who had high risk early stage disease because their cancers did not respond all that well to neoadjuvant therapy. neoadjuvant HER2 therapy and randomized those patients to either the standard back then, which was just continuing trastuzumab, or using TDM1. And the TDM1 showed about almost a 50% reduction in recurrences compared to trastuzumab. So that's now the standard of care. One issue was that the brain metastases actually was not significantly reduced with TDM1 compared to trastuzumab. And I know that goes against a little bit about what I just said about brain metastases, and maybe we can talk about why that might be in our very interesting question and answer period that's going to follow this talk. But it has led us to do this study in the Alliance where we're taking those patients who had residual disease after neoadjuvant therapy and randomizing them to TDM1 or TDM1 plus this potent HER2 tyrosine kinase inhibitor called tucatinib. And this study is underway here at Yale, so you can put patients on this, and I will designate that by the handsome Dan icon, as you'll see for the rest of the talk here. We also were looking at whether you can use the very well-tolerated nature of TDM1 to de-escalate therapy in patients with earlier or lower risk HER2-positive disease. So my then colleague at Dana-Farber, Sarah Talani, and I did this investigator-initiated trial looking at patients with stage 1 HER2-positive cancers, randomizing them to the previous standard, it was actually established by Eric, of paclitaxel and trastuzumab, or TDM1. And the TDM1 was associated with incredibly good outcomes. There was less than 1% distant recurrence at 5 years. So clearly this was effective. We had assumed it was going to be much better tolerated than the taxane trastuzumab regimen. And it turned out it had less, some of the standard chemotherapy toxicities, but people were discontinuing the TDM1, which was given for a year in this study earlier than they were discontinuing the trastuzumab in the other arm of the study. So that's led Sarah to go on to do this second version of the study, comparing just 6 cycles of TDM1, because we think that might be all you need, versus the same control arm. Again, this is a study that's ongoing at Yale, and it's actually a very good study for these patients, in my opinion. There's also studies looking at TDXD, this more potent ADC. This is a study actually comparing TDM1 to TDXD in this adjuvant setting, and then there's a neoadjuvant trial as well. Okay, so switching gears a little bit, and this I think is where it gets really interesting. All the data I've showed you before is for these HER2 amplified cancers. These are the cancers that have incredibly high levels of HER2. In breast cancer, there's actually a continuum of HER2 expression. So you got these super high amplified cancers with 1 million or 2 million copies of HER2, and then you've got everything in between, moderate, lowish levels of HER2, 100,000, 50,000 HER2 proteins. And we call those HER2 low by immunohistochemistry. They're called 1+ or 2+, but they're not amplified. And then you have the very negative cancers, which we're going to call HER2 negative. And it turns out that these lowish levels of HER2 are very common. In fact, the majority of breast cancer has some level of HER2 expression. So given that, and given that we have this monoclonal antibody called trastuzumab that we know works with chemotherapy, the NSABP did this very large trial where they took patients with HER2 low early breast cancer and they randomized them to chemotherapy with or without trastuzumab, the same thing that had shown to be very effective in HER2 amplified cancers. Unfortunately, this was completely not effective. So adding trastuzumab for these HER2 low cancers did absolutely nothing. And you can see the IDFS hazard ratio is 0.98, shows randomization was very effective there, but no benefit. So then, because trastuzumab works by, at least in part, by inhibiting HER2 signaling, it suggests that HER2 signaling really isn't important in these HER2 low cancers. So blocking it doesn't do anything. But it's still there. The HER2 is still there. And we have an antibody-drug conjugate, which is basically looking for a target. Can we use these antibody-drug conjugates to use the HER2 that's on the surface of these low cancers just as an address, a place, a way to deliver our cytotoxic agent? So we had TDXD, and in the phase 1 trial of TDXD, we did have some cohorts of HER2 low cancers, and it actually looked like there was some activity in these HER2 low cancers. So that prompted this very large trial of patients with metastatic HER2 low breast cancer. Again, the most common kind of breast cancer there is, 60, at least 60% of breast cancers, and randomize them to TDXD or chemotherapy, because chemotherapy was a standard for these non-HER2 amplified cancers. And TDXD was much better than chemotherapy in terms of survival, progression, response rate. And that led to the approval of TDXD in these HER2 low cancers, the first approval of anything in HER2 low cancers, because it really wasn't a thing before the drug worked there. And it said, well, okay, if it worked in these HER2 low cancers, and in fact, I talked about that there's these 1+ level and 2+ levels. 2+ is more than 1+. In the trial, actually, the efficacy was pretty similar between the 1+ and 2+. So that kind of begged the question, okay, well, can you go? How low can you go? And in about 20% of cancers, there's like really marginal levels of HER2. So not even 1+. It's just like you can, if you look real close, you can see a little smidgen of HER2 on the surface, but they're not completely stone cold zero. And so just another trial that was just presented over the summer, almost the same trial as I just showed you, but now slightly different setting. But now this trial included a population of these what we're now calling ultra low cancers. So just the smallest amount of HER2, not enough to be 1+. And what was seen, surprisingly, somewhat, was that actually TDXD was much better than chemotherapy in these ultra low cancers. Seemed like the benefit was pretty similar to what we saw with the low cancers. Survival also seemed to be trending in the right direction, although immature. But I think what was particularly important, or what was striking, was that response rate in these ultra low cancers was 62%. These were pretreated patients. You can see that it's actually the response rate in the ultra low is pretty similar to the HER2 low. And again, we can kind of talk about why that might be towards the end. It's funny, when in some of the original steering committee meetings of TDXD, when the original ultra low data, when the original HER2 low data came out, I remember one specific person raising their hand and say, well, why don't we look at HER2 zero cancers? And it was like, everybody kind of laughed because it's a HER2 targeted drug. Of course, it's not going to work in HER2 zero cancers. But it seems to work in these ultra low cancers. And now there's a question of, could it even work with pretty undetectable levels of HER2? And to test that, Adriana Kahn is doing this IIT looking specifically at HER2 zero cancers, treating with TDXD, and then using some of David Rim's very sophisticated assays for HER2 to see if you can really identify whether there really is a threshold of HER2 expression below which you don't see activity. So that study hopefully will open very soon. So what have we learned about HER2 ADCs? So clearly, they're superior to trastuzumab and chemotherapy, both in early stage and late stage disease. TDXD is better, more efficacious, at least, than TDM1, but it also has more toxicity. And I think that likely reflects the trade-off for these cleavable linkers versus non-cleavable linkers. You get the bystander effect, but the bystander effect also can hit normal tissue, not just to other tumor cells. And this very interesting finding of TDXD being affected even in minimal levels of HER2, which may be because of this bystander effect, although we haven't proven that. So I just want to take a slight divergence here and bring up this question just because I think it's really cool, of the fact that given that we have these very effective HER2 therapies, progression-free survival of 30 months and, very long durations of response. And there's actually 8 drugs now approved for HER2 positive disease, different mechanisms of action. So given all of these highly effective drugs, can we really move the needle of treating patients with metastatic disease and go away from treating in a non-curative setting, which is the way we do it now, and move it to a curative setting? And for those of you who don't treat patients with metastatic disease, nowadays we treat with one treatment, we wait for the cancer to become resistant, and then we switch to the other drug. And we try to string along our treatments to keep patients with disease control as long as possible, because we know we can't cure them. So there's no use giving a lot of, kind of piling on your therapies. You want to stretch them out so they last as long as possible. But by doing that, generally you're going to get resistance because you're only giving one drug, and eventually the cancer is going to learn to become resistant. And that's why metastatic disease is typically felt to be not curable. So maybe that's not true, though, given the fact that we have these highly effective drugs. And so a trial that's going to be launched here at Yale shortly, that's being run in this consortium called the TBCRC, is trying to address, can we cure HER2-positive metastatic disease? So to do this, we're going to deviate from the normal practice and take newly diagnosed patients and treat them with 12 weeks of a taxane and trastuzumab, and then give them TDXD for 18 weeks, and then give TDM1 with the kinase inhibitor, and then give more kinase inhibitor for about a year, and then just stop treatment and just follow patients with ctDNA and CAT scans, with the idea that we're going to try to improve the percentage of patients who don't have progression after 4 years, essentially are cured. This is the way leukemias are treated, lymphomas are treated. You pile on lots of different drugs, in a very intensive way, even though kind of leukemia is kind of metastatic to begin with, but it works. Can we do that for a solid cancer? In the past, we really just didn't have the effective therapies to do that. Now that we do, can we change the paradigm? So this is a trial that should open soon here. And again, I think it's really worth exploring. It may be wrong, it may not work, but it's worth trying. Okay, enough of HER2. Other targets. So I guess I realize I have a slide on HER2 here. So when we were, those of us in the field were working on HER2 ADCs, we said, hey, this is great. These drugs are working really well. But it's probably just because HER2 is just this amazing target for an ADC. Why is it amazing for ADCs? Well, first, you have tons of it on the surface. And so the more protein you have on the surface, the more ADCs can bind, and therefore the more ADC can get inside the cell. The normal tissue tended to have very low amounts of HER2. The internalization of HER2 is very fast, and it doesn't downregulate. And you can see in this photomicrograph, if you coat the cell with a fluorescent trastuzumab and then wait a few hours, all of it gets inside the cell. So all those HER2s are getting internalized, which if there's an ADC attached, it'll bring it with it. So internalization is important for ADCs. And the tumors are addicted to their HER2. As I said, it's the HER2 that's driving these cells, so they really need the signaling. So it's really hard for them to downregulate as a way to escape the effects of the ADC. So we thought, hey, it all makes sense that these drugs are going to work in HER2, but they're probably not going to work with other targets because the other targets don't have all these great characteristics. Fortunately, I was wrong, as often is the case. We now have 12, I think roughly 12 ADCs that are FDA approved, and you can see across a wide range of targets. And I forgot to mention TDXD just got approved yesterday for treating those ultra-low patients, so that's kind of exciting. Another group of cancers to be treated. But you can see we have activity of ADCs across liquid tumors and solid tumors with a broad range of targets. So I'll talk of just a brief, in the last few minutes, some of the other targets. Trop2 is being tested, has been validated in breast cancer. It's being tested in other cancers. So Trop2 is a cell surface protein that's pretty widely expressed in breast cancer, associated with the worst prognosis. And there's a drug called sacituzumab govitecan, which is an ADC, also with a topoisomerase payload. And it's set up its linker a little differently. So in addition to being cleavable inside the cell, it's also cleavable by low pH environments outside the cell. So it can release the payload both extracellularly and intracellularly. And it's been tested in triple-negative breast cancer compared to chemo, where it's much better, and it's approved in that setting. And its toxicity profile is different than PDXD's. It's all myelosuppression and a little GI toxicity. And interestingly, Datopotamab deruxtecan, which is another Trop-2 ADC, same antibody as sacituzumab, same class of payload as sacituzumab, but with a deruxtecan linker, which is a little different. It's purely protease cleavable. It's not pH cleavable. And this is an active drug. In the phase 1 trial, we showed that it was active, and even in patients who had already progressed on sacituzumab, there was some activity. But interestingly, again, same payload, essentially, same antibody. The toxicity is completely different. So there's virtually no myelosuppression with datopotamab. Stomatitis is the toxicity, showing how important those linkers are in driving the characteristics of these ADCs. Datopotamab actually just got approved last week for hormone receptor positive breast cancer based on another study. And then lastly, HER3, which is another tyrosine kinase. Actually, it's not a tyrosine kinase. It's related to the other tyrosine kinase, the HER2, HER family tyrosine kinases. It itself doesn't have an active kinase, but it's important in signaling and is overexpressed in a number of breast cancers. And there's a conjugate called HER3-DXd or pertuzumab deruxtecan, which we showed also has activity across breast cancers. But not really sure how this one's going to get developed because the field is getting crowded. Lots of antibodies with the same payload, so where this one's going to fit in is unclear. So there are other conjugates being developed. There are ones with fancy new protein structures. So there's biparatropic ADCs that bind two different epitopes of the same molecule. There's bispecific ADCs binding two different molecules. There's probody conjugates that get activated in the microenvironment. There's new payloads beyond very potent cytotoxic drugs. There are targeted therapy kinds of payloads like kinase inhibitors and apoptosis promoting drugs. There's immunomodulatory payloads, radionuclides, and there are new antigens not targeting the tumor anymore, but actually targeting the microenvironment. All of these things are currently in development. So lots more to come. I just wanted to close by bringing up a few what I think are important unanswered questions. One is, and this is a little wonky, I appreciate, should we be making more ADCs with non-cleavable linkers? Right now, TDM1 is the only approved ADC with a non-cleavable linker. All the other ones have different types of cleavable linkers. There's reasons for the cleavable linkers. You get the bystander effect, but you also get more toxicity. And I always wondered whether if you took a really potent cytotoxic drug and made it with a non-cleavable linker, whether you could get efficacy and still keep the toxicity down. Because TDM1 is still really the only drug with that really favorable toxicity profile, which again was one of the original visions of an ADC. How should we sequence ADCs with different targets? So I mentioned we had a trial where we used the same target but two different payloads, one ADC after another. What about the opposite? And now we have the tools to do that. So in the TRADE trial, which is going to open here hopefully soon, patients are going to be randomized to either T-DXd or datopotamab, the Trop-2 ADC, and then when they progress, they'll switch to the other one to see, and then we'll try to figure out using biomarkers which is the best sequence for each individual cancer. We don't know how to do that yet. And then lastly, and this kind of gets back to the point I made at the beginning, can we get rid of conventional chemotherapy altogether? Ideally, why would you use conventional chemotherapy, which goes everywhere in the body and causes nonspecific toxicity? Why would you use that when you can link it to an antibody and deliver it to the cancer cell? To do that, you're going to need ADCs with different payloads. Just like in practice with metastatic disease, we use chemotherapy A, patients progress, we use chemotherapy B, and so on. You could do ADC A, ADC B, each just switching payloads. The problem is we don't have those drugs other than TDM1 and T-DXd I showed you. We don't have a lot of different payloads, and that's partly because the success of trastuzumab deruxtecan was so high that everybody's jumping on the bandwagon of these topoisomerase inhibitor payloads. And you can see this is from a review that just came out showing the different payloads that are being used. There's 107 in clinical development using camptothecans are basically topoisomerase inhibitor payloads. almost all of them, as shown in this graph, are topoisomerase inhibitors. So they work, but we're getting very crowded. And you can imagine, and we have data now developing, that cancers can become resistant to the payload by mutating topoisomerase. And then once you've got resistance to the payload, it doesn't matter which antibodies you hook up to it, it's not going to work. So we need to diversify our payloads. So with that, I will stop. I'm happy to take questions. Oh, Dan.
Excellent talk, Ian. I have
Thanks.
two questions. Number one, I'm fascinated by this observation about responses in brain metastases. It's known that in hyperproliferative vascular endothelium that HER2/neu is expressed. Have you looked at the HER2/neu expression in the vascular endothelium in addition to the tumor cells in those brain mets? Because it would certainly make sense if they have a bystander effect that may be the actual mechanism of action. And the second question is about interstitial pneumonitis. This is something we've seen with enfortumab vedotin. It's not really clear whether that's because of the interaction between checkpoints and the enfortumab, but what do you think is the mechanism with the HER2 targeted agents with that?
Yeah, so both good questions. When you look at I don't know, I haven't seen data on looking at the HER2 expression on the vasculature around tumors specifically in solid cancers. It's a great question and should be able to be looked at. We do enough, resections of these cancers. It's the alternative. So if it's not just breakdown of the blood-brain barrier, is it release in the microenvironment? There are some data that I didn't have time to show you. But I think very provocative data that was presented at our San Antonio breast cancer meeting last month, just as a poster, because I don't think people appreciated the impact, suggesting that it's actually cathepsins in the microenvironment that are actually cleaving these conjugates, and that's why they work in, potentially HER2 null or HER2 very low, because really you don't need the HER2. It's just the microenvironment has enough cathepsins there that you get selective cleavage around the tumor. So that could be an alternative explanation. But also, if you had anchoring because of HER2 overexpression in the vasculature, you could imagine having efficacy there. And perhaps causing more disruption by causing some apoptosis of the endothelium, causing more disruption, allowing more ADC in there. So I think that's a great question, and I don't have a great answer for that. And in terms of the ILD, we don't know the mechanism. Actually, Adriana Khan is looking at trying to do lung biopsies in patients who get pneumonitis or who are getting these drugs and get pneumonitis to try to kind of clarify that. Certainly there is HER2 in some lung tissue, whether it's through direct target mediated, although as you pointed out, there are multiple targets that are seeing ILD. There are, with TDM1, which is HER2 targeted, the ILD rate is very, very low. And so we have ILD in some drugs where you change the payload or change the linker and you change the ILD rate substantially. So we don't know, is it macrophage uptake because of FC receptors? I think there's a lot of hypotheses, but I don't think there's any definitive data. And it is certainly a problem for some of these drugs. It limits their applicability. Thanks. Yeah.
Okay. Thank you for your talk. I had a question about the brain mets. Have you seen any co-expression of cell adhesion molecules that you could then use as a HER2 bispecific to increase internalization in those brain mets specifically, or the potential?
Yeah. So I mean, again, this gets back to Dan's question, and that whether we can learn from some of these data sets where people are doing resections of brain metastases and looking at dysregulation of adhesion molecules and as a way of potentially doing bispecifics. I mean, there have been some ADCs looking at those adhesion molecules to try to get at the microenvironment, but I don't know of any that have with HER2, but it's a good idea and kind of looking at that because again, the brain met issue is a real problem, and where we see benefit with ADCs in the brain, as I showed you, but they're not eliminating the brain metastases. And generally, what we see with our patients, once a patient has brain metastases that's progressed after radiation, they always progress in the brain, and so it becomes the rate limiting step for a lot of patients. So we need new treatments, but that's a good question. Yeah.
Great talk, Ian. I'm one of the breast and molecular pathologists. The trial you presented with Otto Metzger, when you predicted the pathologic complete response by the heterogeneity in HER2. We encounter heterogeneity on IHC all the time, and sometimes when we go for fish, it doesn't translate to heterogeneity in fish in this area. But also in fish, any fish I review, there is negative cells in the fish. How can we make this clinically applicable? And can this patient go instead of getting new adjuvant antibody-drug conjugate because they're not going to achieve BCR with the regular regimen? Thank you.
Yeah, so I mean, with TDM1, we've definitely seen in both of the studies I showed you and pretty much every study of TDM1, which again, non-cleavable linker, very dependent on HER2 expression, that you see substantially less activity as you go down to either lower expression levels of HER2 or heterogeneity. But in truth, we don't use TDM1 in the neoadjuvant setting. It's not clinically used. And as Eric has been prodding me for years to go back and redo that trial of heterogeneity with one of these conjugates that has bystander effect to see whether we eliminate that disparity. You would expect we would if the hypothesis was correct, but we haven't proven it. But as I said, there's a big trial that's been completed. We're waiting for the results. Should get it sometime this year of neoadjuvant TDXD, the one with the payload spreading, the one with bystander effect, and hopefully, I'm not involved in that trial, but hopefully they'll look at that question and hopefully we won't see that just big disparity by HER2 level because of the unique features of this conjugate. But if we do, then again, it brings up your point and says, hey, a one-size-fits-all approach is not right, and the heterogeneous cancer should be treated in different ways, which probably is, I didn't have time to talk about resistance or biomarkers, but we're not good at figuring out either one of those areas right now. We need a lot more work on identifying whether there are biomarkers that predict benefit of any of these drugs. We haven't been able to figure that out yet. Eric, do you have a follow-up?
Question from online. So this is the limitation of PAT-CR versus long-term outcomes. Because someone doesn't achieve a PAT-CR doesn't necessarily mean they're going to have a recurrence of their cancer. So some of those cells that may be HER2 negatives may also be ER positive and respond to endocrine therapy, may be biologically less aggressive. So it's not absolutely the case that you have to eradicate every single one of those cells. The question online was, do you think it would be possible using antibody-drug conjugate technology to deliver non-chemotherapy agents like immune checkpoints or such?
Yeah, so it's a great question, and there's been a lot of interest in delivering everything with that antisense. As I said, DNA damage repair inhibitors. I think you name it. I think the problem, the concern people have with going that direction, not that it's not being tried, but the concern is just going to be, the amount of ADC that actually gets to the tumor cell is very low because they get taken up, even though, we talk about it being a guided missile, most of the drug actually ends up in just random tissue just because antibodies get stuck places. So, data suggests that like 1% of the dose that you give actually gets to the tumor. So you don't really getting a whole lot of the payload to the cancer cell. And so there's been a push to get very high potency payloads with the idea that you can get away with that because they're being somewhat selectively delivered. because we're not getting a whole lot into the cancer, so you want what you get in there to be very potent. And the problem with most of these small molecules is that they're not as potent as they need to be, or the concern is they're not as potent as they need to be. We'll see. I mean, again, there's a lot of them in development, but that's the problem with your payload. Is if it's not quite potent, it may not be effective enough, even if the general hypothesis is a good one of doing that. So, but none of them have been approved as far as I know. We'll have to see as they pan out. It's a good idea. Did you have a question? Oh, yeah. Is autoimmune toxicity? So, well, autoimmune meaning anti-antibody. Yeah. Anti-human antibodies or anti-conjugate antibodies don't seem to be a big problem with these. It's a good question because you would expect you've got a humanized antibody, you've got derivatization of that antibody. Could that be immunogenic? It hasn't been a problem. You don't see much hypersensitivity with these. I mean, you can at low percentages, but anti-ADC antibodies haven't been clinically significant. In autoimmune disease really hasn't been. Whether the pneumonitis that we see could be an autoimmune reaction is certainly possible, but other than that, we really haven't seen it. Yeah, so meaning if the ADC is encounters an immune cell, it kills it because of the cytotoxic moiety. Yeah, I think that's certainly possible, and that's a good thought. Fortunately, as I said, clinically, it just really hasn't been an issue.
Hey,
Mike?
I had like 20 questions, but I'll try to limit it because so with the ultra low, you're assuming that you're dealing with probably a small percentage of cells that are actually expressing.
By definition.
I guess I understand the idea of cathepsins doing this, but I guess the other question is for the spreading effect. Do we think this is apoptotic cell death, or do we think this is cell death that's actually messier? And if so, has anyone thought of immune in combination, like PD-1?
Yeah. So I didn't talk about biomarkers, didn't talk about resistance.
One last thing, I don't want to forget. For Adriana's thing, I know David Rim is going to be doing QIF. Are you also going to be doing IHC at the same time? Because I think you sort of go on to do both. Because, I mean, at least David's not here, right? He's been dissing,
yeah, we're actually so the actual
correlate.
The actual analysis plan is to do multiple HER2 assays, both protein and genomics, to try to come up with the best predictor. So good question. In terms of immunogenic cell death, it certainly looks like these are causing immunogenic cell death. Again, the payloads are standard chemotherapies essentially, and you're getting a lot of it. They're potent. So there are actually some interesting papers. You get particularly good immunogenic cell death for reasons that I don't know how well they've been validated. And there are combinations of ADCs plus checkpoint inhibitors which have shown some promise. In smaller studies, there's some studies that have shown incredible, response rates, 80, 90%. And there's been some small randomized trials of TDM1 plus checkpoint inhibitors, which show a signal, but not overwhelming signal. So I think we'll have to wait for. There are randomized trials right now with the Trop-2 ADCs, with or without checkpoint inhibitors, being conducted, and we should have the results actually pretty quickly. The hope is that those are going to be, really impressive combinations, both because we know that checkpoint inhibitors plus chemotherapy work well in triple-negative breast cancer, but particularly because of the having an antibody there, maybe you're getting more antigen presentation, maybe you're getting more immunogenic cell death, that it's really going to be truly synergistic. So it's a great question, and we'll have data by the end of this year on that. Barbara? Yeah.
Wonderful talk. And I'm so fascinated by the HER2 low because I guess I think we have some head and neck cancers that are like that. But so, you know, in the amplified, you always have the same target and you're just changing your payload, you're changing your linker, and it keeps working for years. And in the HER2 low, I'm assuming that to the extent that that HER2 is doing something biologically, it's heterodimerizing with EGFR or HER3, right? And so I wondered either with a pan-HER kinase inhibitor or, you know, cetuximab or something like that, have there been attempts to kind of co-target what HER2 is hanging out with in those cancers?
Yeah, so great question as always, Barbara. So as I was going to tell Mike, you know, so we didn't talk about biomarkers or resistance. We also didn't talk about combinations. Combining things with ADCs has been more complicated than we would like. The checkpoint inhibitors actually are an exception. There have been studies looking at kinase inhibitors for the reason you talked about. So far, the data don't look great. It's funny you bring that up. Jingdu and I are just in the process of submitting a concept for the combination of a HER2 ADC plus the HER3 ADC that you're working on for that very reason. Also knowing that HER3 gets upregulated when you block HER2, can you leverage that by combining those two ADCs? But just from lots of unfortunate personal experience, combining ADCs with other drugs has not been as easy as we would have thought. Even TDM1, which is such a good toxicity profile, it's been hard. So.
All right, thank you very much.